what we're going to go through today, a lot of the work that we do at Mummy Star, it's very much the onus is on sort of the focus being on mum and maintaining a normal pregnancy as much as possible in spite of a cancer diagnosis, which often will totally upend the experience for those families, but also for you as health professionals supporting that family. It can be a really scary time, unnerving. You can question your own professional instinct as to how you can best support that family as that cancer diagnosis unfolds. And a lot of the role that we try and do at Mummy Star is to try and instill that confidence within you to be able to continue a normal care, with those families as much as possible, irrespective of the cancer diagnosis that's been going on in the background. But what we've started to move towards over the last few years is that wider recognition that traditionally, when we're talking about cancer symptoms being seen by people, if people start to get concerned about something that doesn't function or feel right, that their instinct is to always, I must see the GP, or I need to go and get triage or an emergency admission to hospital. But what we want to try and get to a position of is where they can start to disclose those symptoms if anything feels unusual to them, but equally to you as a health professional when you're examining somebody, when somebody's having, let's say, a 20-week check-in, or you have that book-in with that family. If they start to disclose something that they're not comfortable with, that you as health professionals, whether it's as a midwife, as a health visitor, as a nurse, have the confidence to know where your referral channel is and how, and understanding better how you play a key role potentially in the opening up of a cancer pathway to diagnosis. Obviously, we hope it never gets to that stage where families are presenting with symptoms. We hope it's something more innocuous than a cancer diagnosis. The sad truth is, with the cases that we see at Mummy Star, which is about 2 women a day being diagnosed with cancer in and around pregnancy of any type of cancer, when we're only likely to see an increase in that figure over the next sort of 10 to 15 years as families start to leave it later into their 30s to start a family, they're inevitably just going to bump into some of the higher age risk categories within cancer, so you're going to see a slightly higher prevalence. That all said, it doesn't mean that when you do see these cases, you will always be as well prepared as you'd hope to. It is a scary time. It can be quite a traumatic time for you as a health professional, whether you're a newly qualified midwife 2 years into practice, or whether you've been in practice 40 years. We've seen the experiences shared with us over the years of many midwives and maternity professionals, and it is really, really hard sometimes to watch these families and be with these families going through these experiences, because it does make you question, what is and is not possible, what is normal, and ultimately, can that family have, the maternity experience that they had hoped and aspired for? But the best way I can frame this is most recently, last week, we held our Cancer and Pregnancy Awareness Week. It's something that we do every year in June, around the charity's birthday. And the onus this year was around seeing the symptoms. So it almost sounds odd when our focus as an organisation is on, mother, maternity and birth. But we actually almost need to, health professionals, when we're talking about symptoms, we almost need to ignore the pregnancy. It sounds weird, but I'll explain. When families are being, starting to go through pregnancy, whether it's a first-time pregnancy for families and they're starting to get used to what does and doesn't feel normal, what is part of the pregnancy, what are the body changes to expect, and versus what should and shouldn't be alarming. When somebody does present often, there's been a culture of dismissal of symptoms, or because symptoms are very, very well hidden during pregnancy. So certainly for any of the atypical breast, abdominal discomfort, gynecological cancer red flags, many of those can be just as easily explained away by the fact that somebody is pregnant. They would be experiencing breast changes anyway. There'd be a lot of change in and around the abdomen, but also gynecological symptoms such as bleeding, early pregnancy spotting. There can be many other reasons for those things to happen other than cancer. What we want to try and get to a stage is where it's always given consideration. Yes, thankfully, it will be the rare time that it's actually just diagnosed, but if we can get into a mindset of always considering what could this be an early sign of, has this woman presented before? Are we listening to her? Can I, as a health professional, actually refer her to the breast clinic or the gynecological clinic or gastro clinic, so that we can make sure that these symptoms are looked at, investigated properly, and then at least that family have an answer as to what's going to happen next. If the worst comes to the worst and it is a cancer diagnosis, obviously the earlier that detection takes place, then the wider the options are for those families in terms of sort of what the outcome for that cancer can be. So we talk about this in terms of our campaign last week was called See Me, and it was about the first part of that was about seeing the symptom. Like I've said, we need to see cancer symptoms in independence of the pregnant body. Yeah, if we look at say we had 2 women sitting in front of us, both of whom are complaining of a discomfort in the breast, and it's been there for several weeks, and you have 2 women, one of whom is 20 weeks pregnant, and the other woman isn't. The chances, sadly, are at the moment that the woman who is not pregnant will probably receive a breast clinic referral very, very quickly. Whereas because the other person is framed in pregnancy, it becomes almost the dismissal or the excuse to be able to say, well, it's probably pregnancy related. You should be expecting various body changes, breast tissue changes, size, etc. Feel and touch. And it's about moving towards the seeing the symptom, outside of the pregnancy, and how would you respond if that woman was not pregnant in your care already? And that starts that pathway then to say, right, if we're starting to look at it in independence, we start to see that woman in independence as well, and listening to her concerns and listening to what her normal feels like. And also for you as a professional, if somebody discloses something, are you alarmed, or are you physically examining somebody, for example, and something doesn't feel normal to you? None of you are oncologists. We're not oncologists. We're not midwives at Mummy Star either. But we get to work with you, with a huge cohort of maternity professionals. And we know that you have that time with families where they will build up that bond of trust with you. And when they're seeing you, whether it's a continuity of care model that you're operating under or otherwise, some of those families are likely to disclose something to you more so than they might do in another health setting where they might have had a negative experience previously, or there's they build up that bond of trust with you to say, look, I saw you 2 weeks ago, this symptom was starting to concern me, but it's not gone away, and I've tried various things. It was like, right, well, what can we do next? What can you do next as the midwife? What does your instinct tell you? If in doubt, make that referral. But I think where we have worked with people over the years, there isn't necessarily that wider knowledge that a midwife can be a referral point. The question we ask is, why does everybody not know that? And I think it's largely because there's the inconsistencies that exist in different hospital settings as to how easy it is to be able to do that, and perhaps what practices have shaped the freedom that we have to refer. But the reality is, whether you're a midwife, whether you're a health visitor, whether you're a nurse, whether you're the obstetrician, anybody that comes into contact, any health professional that comes into contact with a pregnant family at any stage during that pregnancy should be seen as and consider themselves a potential point of referral. And ultimately, you start to become, I suppose, the creator, if you like, of that cancer pathway. Because if you have a family sitting in front of you, why push them back out into the community setting? Why push them back into a GP if you're already in a position to make a simple referral and get them that referral? GPs, as we know, are quite overloaded already, and I think they come in for a hard time with regards to cases like this where people are presenting with symptoms and they feel like they're not listened to. But a lot of the time, GPs are referring people through, and they get met with an age threshold where, despite the number of red flag symptoms that a family are presenting with, the referrals are knocked back because those families are too young. And it's a phrase that we sadly hear way too often in cancer circles is, well, she was too young. Why would she be considered for that type of cancer? The point is, if the red flags are there, the age shouldn't matter. And if you're already in a midwifery setting, you can hopefully be able to push those referrals through straight into the clinics within those hospitals that you're already at and circumvent some of that potential delayed time. So symptom masking, like I touched upon, it can happen in many different cases, whether it's, we try and encourage families, any discharge that they felt during pregnancy, get it checked. Any abdominal discomfort that doesn't feel right, again, get it checked, go back to your midwife, tell them again that it's, that symptom has not alleviated since you last saw them. But likewise, even if you are seeing somebody, if that person is not disclosing something to you, but you can physically see a change in somebody's body that does not look normal, obviously make the family aware, but make them aware as to why you feel that referral needs to be made. Yes, we will, whenever we mention, I suppose, the word referral to a specialist clinic, we're always going to create some anxiety and worry in a family, but it's surely better to create short-term worry, to seek a solution or seek reassurance long-term, than it is to just leave it and then potentially something gets caught at a much later stage where the options are far less wide than they hopefully could be at an earlier stage. So likewise, the more we can do this, it obviously lends itself well to an earlier detection ultimately of that cancer. Like I said, if indeed, thankfully, most of the time we would get somebody referred through, it would just be diagnosed, for example, as something like a benign cyst in the breast, or somebody just having, say, lumpy breast tissue, and it just it becomes even more profound during pregnancy. But again, for those families where we do manage to get something investigated, and there is that earlier detection of a concerning symptom, the quicker that clinical referral is made, the more those diagnostic tests can then be done at an earlier stage. With pregnancy, we know that diagnostic challenges do exist because of the various stages people get diagnosed at, or certain scans that are not able to be done once somebody is further into, say, the second or third trimester than they would be in the first. But equally, it's about making sure that those families at least have the opportunity to be able to see somebody, to be able to have those checks done. And if it does ultimately get to a detection of a cancer or a concerning sign, that at least there is the start of the follow-up. and the regular checks and monitoring as the pregnancy continues, so that you can keep an eye on anything that becomes even more concerning or that needs immediate intervention before we get to a potential point of diagnosis. Explore the symptoms. This might seem obvious when we're talking about earlier detection, but what we mean by this is the Embrace report has now for several years has reiterated that we need to, when people are presenting with symptoms of concern, whether it is cancer related, whether it's to do with another serious health condition, the point is that it's not good enough anymore to diagnose what it isn't in a person when they're presenting. So if you send one of these women, say for example, through to a breast clinic, and they're told, as that previous example, that it's a benign cyst, but that pain continues and those symptoms continue that are concerning her. Well, just because she hasn't been given a diagnosis of cancer, is there something else that's going on? Because it's still concerning her, it's still causing anxiety. And at the end of the day, we don't want somebody to be going through their pregnancy in a heightened anxious state. We want them to be able to be in a more relaxed, calmer state, and knowing that there is investigation going on. So we need to seek a diagnosis of what something is all the time. If the first check doesn't show up something, then it needs to be followed up again and again until you get to a point where you can say the cause of this symptom is X, rather than just constantly saying, don't worry, it's not that. That does not alleviate the concern in the person if the pain doesn't go away. Likewise, people, they get concerned about representing, especially I think in a post-COVID era when there's still very much a culture that exists of people being concerned about putting pressure on GPs and putting pressure on services. It's reiterating that message that the NHS is open, and if you are having concerning symptoms throughout at any stage of a pregnancy, just as equally postnatally as well, is that you do go and get checked, whether it's a virtual appointment, whether it's an in-person appointment, is at least make the appointment in the first place. Be your own advocate, as well as for the role that health professionals can play in actually getting to a point where we start to explore. The more we explore those symptoms, the more we can rule out hopefully the less serious issues. But ultimately, it just goes to alleviate concern of those families as they're going through that pregnancy, and we start to draw back onto an enjoyment and the fulfillment of that pregnancy. If we do sadly get to a stage where a cancer is diagnosed with a family, if we've done all that, then you as a midwifery professional are able to proceed with the care of that family, knowing that the cancer has been picked up and has been diagnosed and there is a treatment plan for that. But the role for you then is to proceed as normal. You're not an oncologist. Your role is not to treat cancer. Our role collectively is that of supporting that family through that pregnancy and trying to maintain as much as we possibly can a normal pregnancy, an enjoyable pregnancy, and one that is based on informed choice and personalized care. So I've touched upon this in various different points, but your role within this is huge. Not to put any pressure on it, because it's more about almost instilling a confidence in you that when you do get faced with cases like this, they are, like I touched upon at the beginning, they are really traumatic. You won't see cases like this regularly, even if you attended one of our study sessions at university 3 years ago, and then you suddenly are confronted with a family that you saw at 12 weeks and everything was absolutely fine and they were really excited and looking forward to everything. And the next time you receive those notes and you realize there's been an oncology intervention since, and that family is sitting in front of you, it's knowing the role that you potentially have played in that and been able to reflect and said, I'm glad I made that referral. I know it's obviously come to a traumatic point for that family where they're having to contend with a diagnosis of cancer, but you know that you picked up on that symptom and that you have had a key role to play in starting that pathway to diagnosis. It could be that thanks to you, because of that timely intervention, that family have actually had way more options from a cancer treatment perspective than they otherwise would have if that diagnosis had come because of an acute admission to A&E, for example, and by that stage that cancer had sadly already advanced to another part of the body. But we're not talking about being able to be, the cure here of that diagnosis if it does happen. It's just about being able to understand that the role is, I've heard it several times over the years where we talk to students and student midwives and we hear the phrase, but I'm just a midwife, how can I play a role in that? But it's actually the total opposite, because you are way more than a midwife. You are far more than the maternity professional title that you have. And it's so all-encompassing in terms of being that family's advocate, being their voice, pushing for their choices in that pregnancy. And in spite of that cancer diagnosis that they may have then subsequently had, it's about making sure that, well, why can't that family have a home birth just because they've got a cancer diagnosis? Does that somehow create more adverse risk than otherwise you would have with any home birth? But we don't stop offering them just because. Likewise, if somebody wanted to have a water birth, for example, and they've had a brain tumour diagnosed, Does that mean that they can't spend any time in the water just because they've had a brain tumor in the same way that we would have with a patient with epilepsy? Does it mean that we can mix and match the delivery mode a little bit, where they can have some time in the water and then they're able to come out after a certain certain point of dilation where they then deliver, outside of the pool? But it's about trying to almost within this setting create a patchwork almost model of maternity care where we take everything we can to try and maintain that family's ultimate desire for that pregnancy and try and create as memorable a pregnancy as possible, in spite of the fact that they've had this deeply traumatic diagnosis of cancer. Because it might sound like a really, really odd way of phrasing it, but in spite of the fact that these diagnoses do happen to families, if you're able to offer that really informed model of care, really compassionate, personalized care model for families and treat, look at each one of their individual circumstances around that cancer diagnosis, you can have families where ultimately the cancer outcome is not necessarily a positive one, but they will reflect back on a really, really positive, really well-supported pregnancy journey, and one that ultimately where the focus became about pregnancy again, where at one point it was actually in danger of being pulled away from them because a cancer diagnosis had come and it was threatening to actually overtake the entire maternity experience. We see it on a regular basis and we see it achieved on a regular basis, whether like I said, irrespective of the cancer outcome, whether that family are in a curative situation or whether sadly that cancer spreads to another part of the body. It's about making sure that the focus is on them as a pregnant family or as a family that are growing their family, and being able to support their choices and support both her in terms of the delivery, but also them as a family and their needs, both in terms of the support of each other and also as to how the different levels of sort of trauma that will come into that family's experience and how they could play in it, whether it's an in-pregnancy diagnosis or whether equally postnatally, where we see all the same issues that I've outlined here in terms of symptoms that are excused away by pregnancy, postnatal bleeds, for example. Women are told that they will bleed postnatally. How long is normal? How long before it gets investigated? How long before something serious starts to get uncovered? All the symptoms that are in pregnancy can be just as well hidden postnatally. So it's just as important from a midwifery setting as it is that we move this message into health, health visitors and anybody else that we could be seeing those families on a regular basis postnatally as well. So just to reiterate the message behind that, it is the see me, it was very much, it's see the symptom, explore thoroughly, lead to earlier detection, and ultimately we're looking at far wider options for families from a cancer outcome perspective. If we can get to that point and we can make sure that everybody who comes into contact, it could be anybody in a maternity sphere comes into contact with a family, that they know that they are a potential point for them to refer or for them to see those potential red flags that those families are presenting with and make the referral through, because we just don't want to be left in any doubt that we could have intervened potentially, and trying to see it from our, I suppose, outside our traditional role that we've worked through for years. Because like I said, this is something that is probably only sadly likely to increase in terms of the instances that we see. Like I said, it's about 2 women a day at the moment. But because of those changing birth trends, it's likely that we're going to see an increase. That's not to say there's causation between cancer and pregnancy. It's just, like I said, it's just the different lifestyle choices, changing birthing patterns, etc., are going to likely see an increase. The main thing, if you do ever come across a family like this and you find yourself actually supporting a family who've already been diagnosed, please do reach out to us as a support mechanism. We're not just there for families, we are there as much for you as we are for anybody else. It can be a point where we get contact from midwives and maternity professionals regularly saying, I've got a family that we're in touch with, I don't really know what to do to help them. And it's just as simple as a phone conversation to say, just talk us through what you're doing already. Most of the time we'll just agree and say, wouldn't suggest you're doing everything that you would do for anybody else. But it's just that, well, I think I said earlier on about, it's that point where you potentially start to question your own professional instinct on how to support a family. We'll always revert back to just support them as you would any other family that comes into your care, because at the end of the day, that's how they want to be seen. They don't want to be seen as cancer patient who happens to be pregnant. They want it the total other way around, which is I'm a pregnant person who happens to also have cancer. And that's where that maintains the focus on the fact that that growing family and that maternity experience can then be protected as much as we reasonably can, and ultimately leads to a more positive, birth outcome for those families. Likewise, with all this, obviously, we do frame this in birth and postnatally as well. But there are many of our families, sadly, where they will experience a loss during that pregnancy, either because of the nature of the cancer diagnosis and how aggressive it is, may lead to the need clinically to intervene and actually end that pregnancy earlier. Just as much in those cases as with anybody else, it's about normal care in the sense that offer those families all the bereavement care that they would normally receive. Because what we sadly do see at times is when there's been a cancer diagnosis in pregnancy and then there's ultimately been a loss that's resulted immediately afterwards, that family's status immediately becomes a cancer patient only, and the bereavement is totally lost. And we see families who don't necessarily receive that follow-up sometimes, depending on the type of cancer they've been diagnosed with. But when we talk about normal care, it's in pregnancy, it's postnatally, it's in bereavement, it's the entire sort of range of experiences that families can happen to make sure that they're treated and focused on. Because in that example, like I've just said previously, they are a grieving family first and a cancer patient second, and they don't want to be started to see as the other way around, because that's when the loss and the compassion and care starts to get shifted away from them. So if there's any questions, if we're on the stall, obviously myself and my colleague Tracy today, if there's any questions that anybody has about anything that we do, you want to know a little bit more about our work, you want to know about the education and awareness sessions that we offer, hospital settings and student midwives and any student health professional as well, please do get in touch and we'll sort of have a conversation. We'll tailor it to your particular setting and the actual time allowance that you guys have as well. So thank you very much.